Well, I'm going to move back a little bit to the mundane here a little bit, and I had to think about a TAVR experience that really beget innovation. So actually, we're going to bring in a case that we actually did a couple weeks ago, but it's actually got a longer history to that. And that is, when we started to do the core valve, self-expanding valve, we were really dealing with data from Europe that suggested that the moderate to severe paravalvular regurgitation rate was 15%, and that was actually probably a good call, a good number. And that's actually obviously way, way too high for what we want to experience now or would be willing to accept. And there were a lot of challenges with the early implantation techniques as we learned about them from our European colleagues. In this particular example, the core valve is functioning well, the gradient's very low, but it's placed about 12 millimeters deep, and there's a substantial amount of regurgitation. It's difficult with this situation to try to pull the valve out. You can do a valve-in-valve as a bailout technique, but obviously this was the major problem. It was our biggest concern as we moved to clinical trials in the United States. And I think we learned from the partner data, which had done a little bit earlier, and we certainly had reduplicated this from the self-expanding series, is that moderate to severe paravalvular regurgitation is a big deal. And I think now there's suggestions that even mild regurgitation over time in the advanced registry suggested that there may be some implications to that. So obviously the design goal is to eliminate that. Very great work by Samir Kapadia got us out of thinking about these ordinal rankings of none, mild, moderate, severe, and we can think more clearly about the fact that if you don't have any, it's good, and if you have a lot, it's bad, and then everything else is a little bit of a gray zone in the middle. So our design goal was really to try to move towards reducing regurgitation. So what do we do? Well, as Dr. Reardon, who's here, we brought the core valve in the United States in 2012 for our clinical trials. We thought about a lot of things. We thought about making sure that we had the right size valve, that we had higher implantation technique using the maximum diameter of the self-expanding valve itself. We thought about the hemodynamic assessment that we needed to use with post-dilatation, and then we needed to come up with better designs. I think one of the take-home messages from self-expanding technology is that you really need to make sure that you're not undersized. We use the perimeter-based diameter. When oversizing ratios were over 20%, we had paravalvular regurgitation rates with the Evolute valve of under 1%. So sizing is key, and I'd still encourage everybody to own the CT process and make sure that you understand the sizing algorithms. Hemodynamics have been controversial about whether we should do them or shouldn't do them with the different valve technologies, and I think that they're still useful and we still do them on a routine basis because one needs to understand how much blood is regurgitating from the aorta back down to the ventricle because sometimes the echo doesn't give you a precise evaluation, and certainly aortography leaves much to be desired. So technique was important, sizing was important, but we had to come up with better designs. The Evolute Design in blue, you'll see, is shaped differently. It's a little bit oversized compared to the classic core valve. It has more of a vertical height to it, so there's better sealing. And then down at the inflow portion, there's actually coverage with the skirt. So the design of the core valve, conformability, oversizing, vertical shoulders, allowed us then to have better implantation techniques with less regurgitation. And actually that has held out in the arena of the Evolute clinical trial, 3.1% at 7 days, 5% at 30 days, 3.7% at 1 year for moderate to severe. But that we also had a little bit of deficiency on sizing, so we had to move into to a 34 realm, which actually took us up to a 30 diameter. Dan O'Hara has presented this data, 30 days and 6 months, 1.7% moderate to severe, and then none at 6 months. So the 34 valve, which has a 36 millimeter inflow to it, down to a 26 millimeter diameter, it's about oversized by 30%, and at the highest diameter, it still has about a 20% oversizing ratio. So without question, good sealing because it's a large valve, self-expanding valve. Now, on most of our clinical practices now, we're using the Evolute Pro. I never thought this was going to work. The Evolute Pro is a pericardial wrap, 1/10 of a millimeter in thickness, increases the surface area by about 80% or so, but that increase in surface area does a lot. And now we know that the moderate to severe paravalvular regurgitation rates from the Evolute Pro are essentially non-existent out to 1 year. And most importantly, 90% of patients had no or trace paravalvular regurgitation compared to 11%. So we've really come a long way with paravalvular regurgitation. We've come a long way because when we started out in the core valve series with better technique, we were 11%, 3.4% with our Evolute, and now down to very, very low levels with the Evolute Pro. And with that, we've also been able to bring down the pacemaker rate because of the conformability to the scaffold and probably the pericardial wrap. But that's not what the case I wanted to show, why we have to beget intervention. I think we've focused in a long way about being able to reduce paravalvular regurgitation, and with better designs and better technique, better sizing, we've been able to do that. But this is a case that we did at our institution, started out about 3 weeks ago. It was an 80-year-old man, end-stage liver disease, a bicuspid right non-coronary fusion, which is a little bit unusual, not that much calcification of the raphe. You can see up at the upper, between the right and the non-coronary. And we had to then figure out how to size. And the perimeter-based diameter was about 88. That would be, if you put that into diameter terms, it's about 28. The sinuses were very big, and one has to ask the question with bicuspid disease, do you do annular sizing or does one supraannular sizing? And I think a little bit later, if Danny is going to talk, he's going to talk about the basilica technique that actually will actually use a wire and radiofrequency to slice the raphe, create that to be a tricuspid valve, and then allow the self-expanding or the balloon expandable to form a more circular shape in these bicuspid cases. This is the calcification that was really within the annulus. Now, unfortunately, I worked really hard with the AV guys. These videos are not going to work, but I want to describe what happened. This was a 34 implant. It began as an implant depth about 10 millimeters or so. When we deployed the valve, it slipped down a little bit further to about 12 to 14 millimeters or so. We did a post-dilatation with a true balloon. Things looked better. It was a deep implantation. The mitral valve was not significantly impacted. The patient, now, there we go. The patient struggled a little bit. Over about a week or so, developed more severe paravalvular regurgitation. And what you can see is the valve has migrated towards the ventricle another couple, 3 millimeters or so. Now, I'm not sure what just happened there. Let's just see if I can get this back up. No, I think we're... There we go. Yeah, maybe it's the laptop piece. So then we had a deep 34 millimeter implant. It was affecting the valve. There was a lot of leakage and the hemodynamics were bad. Question is, what do you do? Do you at that point in time try to snare the valve and pull it back up? Or do you put another valve in place? And because we were relatively deep, we thought what we'll do with this another 34 valve is place it right at the annulus, which is what we did. Unfortunately, these videos are not going to work. And then we ended up post-dilating it and ended up with this morphology of a valve-in-valve and mild paravalvular regurgitation. All right, so bicuspid valve, large annulus, large valve, a deep implant, slipped in, had to deal with that issue, came back, now we did a valve-in-valve with the annulus and got a good result, and he's actually doing fine now. So we're not done yet with dealing with paravalvular regurgitation, and I think that that's going to lead us to different techniques for bicuspid disease and different types of valves that we'll be using. What is clear for paravalvular regurgitation as a design goal is we've reduced it. We've been able to do better implantation techniques. We've been able to size better. We've got now PVL rates down to 1 or 2%. But I have to say that one of our unmet challenges is going to be bicuspid disease. I hope we'll talk a lot about it at this session. It's a different animal. We might have to do different techniques like slicing the raphe to allow more circular configuration. We may have to do different sizing techniques, supraannular sizing, and potentially use smaller valve. But ultimately, I think in the pipeline and soon to be there is what we really need in these cases is a fully retrievable and fully repositionable valve. Thanks for your attention.
Thank you very much.